everyone, it's Dr. Campbell, and welcome back to another ICD-10 CM coding guidelines session. Today, we are still climbing our way through the chapter-specific coding guidelines, and today we're going to focus on chapter 19. Guys, can you believe we're on chapter 19? So chapter 19 is for injury, poisoning, and certain other consequences of external causes, code family S00 through T88. So the first thing that you'll want to know regarding chapter 19 codes is that most, not all, most of them have a 7th character requirement for each applicable code. Remember guys, way back when we first started going over the guidelines, we actually spoke about 7th characters. So most of the codes in this category, with the exception of fractures, have 3 options. Those 3 options are A, initial encounter, D, subsequent encounter, S, sequela. Let's talk about A first. So the 7th character of A, initial encounter, is used for each encounter where the patient is receiving active treatment for the condition. Now guys, the patient may be seen by a new provider or a different provider over the course of the treatment for an injury, but that 7th character of A is assigned while the patient is undergoing active treatment, not whether or not this is the first time that the provider is actually seeing the patient. Now, in those situations where we have a complication code, active treatment actually refers to treatment for the condition that's described by the code, even though it may be related to some earlier precipitating problem. So the key here, guys, is active treatment. So if a patient comes in for an infection because of a prosthetic device, if they're being seen for active treatment of that infection, you're going to go with the 7th character of A. 7th character of D, subsequent encounter, is used for encounters after the patient has completed active treatment of the condition and they're receiving routine care during what's known as the healing or the recovery phase. Now, I want you to know that there is something called Z codes, and we're going to talk about those in chapter 21. But in the Z code family, we have codes that are known as aftercare Z codes. The aftercare Z codes should not be used for aftercare for conditions such as what's in this chapter, injuries or poisoning, where there's a 7th character that's available to specify subsequent care. So for example, aftercare of an injury, you're going to assign the acute injury code, but you're going to have a 7th character that says, hey, this is the subsequent encounter for that acute injury. Lastly, the 7th character of S for sequela, that is for use for complications or conditions that arise as a direct result of a condition, such as in the case where a patient has a scar that's formed after a burn. The scar is the sequel or the sequela to the burn. When you're using the 7th character of S, it is necessary to use both the injury code that precipitated the sequela and the code for the sequela itself. The 7th character of S is added only to the injury code, not to the sequela code. The 7th character of S identifies the injury that's responsible for the sequela, and then the specific type of sequela, such as the scar, is sequenced first, followed by the injury code. All right, guys, speaking of injuries, let's talk about coding injuries. When you're coding injuries, you are going to assign separate codes for each injury unless a combination code is provided, in which case you're going to use the combination code instead. Now, there is a category T07, unspecified multiple injuries. That code should not be used in an inpatient setting unless you don't have any other options. Also, traumatic injury codes S00 through T14.9 are not to be used for normal healing surgical wounds or to identify complications of surgical wounds. So let's talk about sequencing. You know, we always have to talk about sequencing. What goes first? So the code for the most serious injury as determined by the provider is going to be sequenced first. It's determined by the provider and it is the focus of the treatment. Superficial injuries. Superficial injuries such as abrasions or contusions are not coded when associated with more severe injuries of the same site. When you have primary injuries that are with damage to nerve and blood vessels, there are some sequencing rules. The primary injury is sequenced first with an additional code or codes for injuries to nerves and spinal cords and or injury to blood vessel. When the primary injury is to the blood vessel or nerves, that particular injury should be sequenced first. Whoa, that was a lot. All right, next up, coding traumatic fractures. Guys, lots of rules here. Now, you remember when we went over chapter 13 and we spoke about your chronic, reoccurring injuries, fractures. Here, guys, we're specifically talking about our traumatic fractures. So, couple of things. We talked about multiple coding a few minutes ago. So, the principles associated with multiple coding of injuries should also be coded with multiple coding of fractures. Fractures of specified sites are coded individually by site in accordance with both the provisions that are within a particular category and the level of detail or specificity that is available in the medical record. Also, a fracture that's not indicated as open or closed should be coded as closed. Sidebar, side note. The physician doesn't have to say the word open or closed. Guys, he can use words that describe an open or closed fracture, such as comminuted or compound, okay? Make sure that you research the different types of fractures so that you are familiar with what's, described as open or what's described as closed. All right, next up, we're going to look at initial versus subsequent encounters. So traumatic fractures are coded using the appropriate seventh character for the initial encounter. Let's pause for station identification. Initial encounter, we know that that's for active treatment. But I want you to know that when you get into the fracture codes, you're going to see more than a seventh character of A. You may see initial encounters that have a seventh character for active of a B or a C. Your tabular list will provide you with further guidance on what the applicable seventh character should be. The appropriate seventh character for the initial encounter should also be assigned for a patient who actually delayed seeking treatment for the fracture or non-union. Fractures are coded using the appropriate seventh character for subsequent care for encounters. And when is this, guys? After active treatment of the fracture, and after active treatment means that the patient is receiving routine care for the fracture during the healing or recovery phase. Now, when we're talking about care for complications of surgical treatment for fracture repairs during the healing or recovery phase, those should also be coded with the appropriate complication codes. Now, care for complications of fractures such as a malunion or non-union, we actually have specific seventh character subsequent care codes. And guys, they're divided based upon non-union subsequent care, malunion subsequent care. So this goes beyond that 7 character of A, D, or S that we saw previously. Now, malunion and non-union. The appropriate 7th character for the initial encounter should also be assigned for a patient who delayed seeking treatment for the fracture or the malunion. Now, open fractures. As it relates to open fractures, the 7th character values for fractures of the forearm, the femur, the lower leg, including the ankle, are based on a fracture classification system known as the Castillo open fracture system. When the Castillo classification type is not specified for an open fracture, the 7th character for an open fracture type 1 or type 2 has some specific 7 characters that should be assigned. Now, if you have a patient that has osteoporosis and they suffer a fracture, you should already know we're not going to use the traumatic fracture code. We're going to use a code from category M80 because remember, that's the one that says the patient has a fracture, but they also have osteoporosis. The aftercare Z codes should not be used for aftercare for traumatic fractures. Remember, for aftercare of a traumatic fracture, we're going to assign, and I know what you're going to say, the acute fracture, yes, with the appropriate 7th character. Lastly, here about coding traumatic fractures, multiple fractures. Multiple fractures are sequenced in accordance with the severity of the fracture. We talked about that before. Next up, we're going to take a look at coding of burns and corrosions. The ICD-10 code set does make a distinction between a burn and a corrosion. Our burn codes are for thermal burns except sunburns that come from a heat source such as a curling iron, a fire, some other hot appliance. The burn codes are also for burns that are a direct result of electricity and radiation. Corrosions, however, are burns that are due to chemicals. And from a coding perspective, the guidelines are the same for burns and for corrosions. Now, let's talk about burns in general. So, current burns are classified in ICD-10-CM by the depth, the extent, and by the agent. So the depth, 1st degree, 2nd degree, 3rd degree, the extent, and then the agent. And those are what are known as codes that start with the X. All right. Now, current burns fall under code family T20 to T25. Burns of the eye and internal organs, those are actually coded in T26 through T28. So now, guys, let's talk about some sequencing. So you're going to sequence first the code that reflects the highest degree of burn whenever you have more than one burn that is present. When the encounter or the admission is for treatment of external multiple burns, you want to sequence first the code that reflects the burn of the highest degree. When a patient has internal and external burns, the circumstances of the admission are going to guide the selection of your principal diagnoses or your first listed. In those situations where the patient has a burn, injury, and other related conditions such as smoke inhalation or respiratory failure, the circumstances of that admission are actually going to govern the selection of principal diagnoses. All right, so burns of the same anatomic site. You are going to classify burns of the same anatomic site and on the same side but of different degrees to the subcategory that represents the highest degree that's recorded in the diagnoses. So for example, if a patient has a second and third degree burn of the right thigh, you're going to go with the highest degree. Non-healing burns are coded as acute burns, and whenever the patient has necrosis of a burned skin, that should be coded as a non-healed burn. Infected burns. For any documented infected burn site, you're going to use an additional code for the infection. Why? Because it is an infected burn. All right. As it relates to coding burns, you're going to assign separate codes for each burn site. Category T30, burn and corrosion, body region unspecified, is an extremely vague code and actually should be rarely used. And when you're talking about coding of burns from multiple sites, that should only be assigned when the medical record does not specify the individual site. Still talking about burns and corrosions. Here we're going to look at burns and corrosions classified to the extent of the body surface that is involved. We have codes T31, burns classified according to the extent of the body surface involved, and corrosion T32 classified to the extent of the body surface involved when the site of the burn is not specified or when there is a need for additional data. It is advisable to use T31 again, burns classified according to the extent of the body surface, as additional coding when needed to provide data for evaluating burn mortality, such as when you're coding for a burn unit. It is also advisable to use T31 as an additional code for reporting purposes when there is a mention of a third degree burn involving 20% or more of the body surface. And our codes in category T31, T32, they are divided based upon the rule of nines. That's the classic rule of nines that you learn. Now, providers may change these percentage assignments where necessary to accommodate for infants and children who, as you probably know, their heads are actually larger than adults. All right, sequela. We've talked about sequela before, the sequel. So encounters for treatment of late effects of burns or corrosions should be coded with a burn or corrosion code, and you know what the next thing you're going to say is 7th character of S for sequela. Now, when you have a sequela with a late effect and a current burn, what do you do? So when it's appropriate, both a code for the current burn or corrosion with the 7th character of A or D and a burn or corrosion code with the 7th character of S for sequela may be assigned on the same record, but it's when both a current burn and sequela of an old burn exists. Of note, burns and corrosions actually don't heal at the same rate, and a current healing wound may still be around with the sequela of a healed burn or corrosion. External cause codes. Now, we haven't talked a lot about external cause codes. That's actually our next session. But an external cause code should be used with burns and corrosions to identify the source and the intent of the burn, as well as the place of occurrence. And again, we'll talk about those in our next session. All right, adverse effects of poisoning, underdosing, and toxic effects. Codes in categories T36 through T65, that's where your table of drugs is, are combination codes that include the substance that was taken as well as the intent. No additional external cause code is required for poisoning, toxic effects, adverse effects, and underdosing codes. Now, you just heard me mention the table of drugs and chemicals. The table of drugs and chemicals is in the alphabetical index. You should never, ever, ever code directly from the table of drugs and chemicals. You want to always go to the tabular list to confirm your code. Also, use as many codes as necessary to completely describe all of the drugs, medicinal, and biological substances that are impacted by today's encounter. If the same code is going to describe a causative agent for more than one adverse reaction or poisoning, toxic effect, or underdosing, you only want to assign one code. Assign the code once. Why? Guidelines state each unique ICD-10 CM code can only be reported once per encounter. If the patient has 2 or more drugs, medicinal or biological substances that are reported, you're going to report each code individually unless, and you know what that unless is, unless there's a combination code that's in the table of drugs and chemicals. All right, so of course we got some sequencing that comes into play with regards to adverse effects, poisoning, underdosing, and toxic effects. So let's start with adverse effects. When you're coding the adverse effect of a drug that has been correctly prescribed and administered, you're going to first sequence the appropriate code for the nature of the adverse effect, followed by the appropriate code for the adverse effect of the drug. So the nature goes first, and then the T code goes second. Now, when you're talking about poisonings, guys, that sequencing is actually reversed. When you're coding a poisoning or a reaction to improper use of a medication, so medication that's overdose, wrong substance, taken in error, wrong route of administration, first you're going to use the code from T36 to T50. Then you're going to use a second code for all manifestation of the poisoning. Of note, if the intent of the poisoning is unknown or unspecified, you're going to code it as accidental intent per guidelines. All right, underdosing. Underdosing refers to taking less of a medication than what is prescribed by the provider or the manufacturer's instructions. Discontinuing the use of a prescribed medication on the patient's own initiative, not directed by their provider, like, oh, I feel good now, so I'm going to stop taking it, is also classified as an underdosing because the patient did not take what the physician had given them to take. So for underdosing, we're going to see codes in category T36 to T50, and you should note that those actually have a 5th or 6th character of 6. It depends on the code family. Codes for underdosing, guys, should never be assigned as a principal or first listed code. Okay, if the patient has a relapse or an exacerbation of a medical condition for which the drug is prescribed because of a reduction in the dose, then the medical condition itself should be used or should be coded. Non-compliance, guys, we have some non-compliance codes should also be used to indicate that the patient was non-compliant with their medication. They're in the Z91 code family. Also, if the patient has a complication of care, we have codes in family Y63.6 through Y63.9 that may apply. All right, and lastly here, we're going to talk about toxic effects. When a harmful substance is ingested or comes in contact with a person, this is actually classified as a toxic effect. Toxic effect codes are in categories T51 through T65. Toxic codes have an associated intent as part of them, which are accidental, intentional self-harm, assault, and undetermined. So you'll let your medical record documentation guide you down the path that you should go relative to code assignment. All right, guys, almost done. This is another long one. Adult and child abuse, neglect, and other maltreatment. So in these particular situations, you're going to sequence first the appropriate code from T74 or T76, T74 is adult and child abuse, neglect, and other maltreatment confirmed, while T76 is the same code, but it's suspected. So T74 is confirmed, T76 is suspected. You're going to code these codes for abuse, neglect, and other maltreatment, followed by any accompanying mental health or injury codes that may be impacting the patient today. If the documentation in the medical record states abuse or neglect, it is coded as confirmed. If it is documented as suspected, you're going to code it as suspected. So T74 confirmed, T76 is suspected. For cases of confirmed abuse or neglect, an external cause code from the assault section, which falls under X92 to Y09, should be added to identify the cause of any physical injuries. Also, a perpetrator code, Y07, should be added when the perpetrator of the abuse is known. For suspected cases, notice this, suspected cases, you do not report an external cause or perpetrator code. In those situations where there's a suspected case of abuse, neglect, or mistreatment, and it's ruled out, meaning it did not happen during an encounter, you're going to use Z04.71 for adult cases and Z04.72 for child cases. In this case, you would not use T76 suspected, because again, if it was ruled out, it was ruled out. If a suspected case of alleged rape or sexual assault is actually ruled out during an encounter, we got codes for that as well. Z04.41 for the adult, Z04.42 for the child. And again, you're not going to use a code from T76. If a suspected case of forced sexual exploitation or forced labor exploitation is ruled out, guys, we got codes for that as well. Z0481 for our encounter and observation of a victim following a sexual exploitation, and if it is for forced labor exploitation, Z04.82, and again, you would not use T76. So I guess the moral of the story is be careful about using T76 when other codes may apply. All right, next up, complications of care. Now guys, remember there is a guideline regarding complication of care, and the physician has to state it is a complication of care. Now, in those situations where you have pain due to medical devices such as implants, grafts left in the surgical site, those are assigned to the appropriate code found in Chapter 19. That's what we're talking about right now. Specific codes for pain due to medical devices are actually found in the T code section of our ICD-10 CM. If your patient has acute or chronic pain due to the presence of those devices, there are also some codes in G89.18, G89.28 that you can add as additional codes. Must be documented. Still talking about complication of care. Here we're going to look at transplant complications. Notice this, other than for kidney. So codes under category T86, complication of transplanted organs or tissues, are used for both complications and rejection of a transplanted organ. A transplanted complication code is only assigned if the complication affects the function of that transplanted organ. In this particular situation, two codes are required. One, the appropriate code from category T86. Two, a secondary code that identifies the complication. Pre-existing conditions or complications that develop after the transplant are not coded as complications unless they affect the function of the transplanted organ. All right, so I know you're thinking, well, what about for kidney transplants? Patients who have undergone kidney transplant may still have some form of CKD because the kidney transplant may not fully restore the patient's kidney function. We have code T86.1, which should be assigned for documented complications of kidney transplant, such as situations like transplant failure or rejection. T86.1 should not be assigned, however, for post-kidney transplant patients who have CKD unless, very important, a transplant complication such as failure or rejection is documented. If the documentation is unclear as to whether or not the patient has a complication of the transplant, of course, you want to query the provider. Conditions that affect the function of the transplanted kidney other than CKD should be assigned a code from subcategory T86.1, complications of a transplanted organ kidney, and a secondary code, guys, for the complication. Now, for patients who have CKD following a kidney transplant but do not have a complication such as failure or rejection, you're going to go back to chapter 14, and we talked about chapter 14 previously. All right, guys, we're going to bring this thing on home. Last two guidelines, still under complication of care. As with certain T codes, some of the complications of care actually have the external cause code built in, or the external cause built into the code. So essentially, the code includes the nature of the complication as well as the type of procedure that caused the complication. In these situations, no external cause code is used because it's already built into that code. Last guideline: intraoperative and post-procedural complications. Those codes are actually found within the body system chapters with codes specific to the organs and structures of that body system. So if a patient has a complication, intraprocedural or post-procedural, related to a cardiac device, those codes are found at the end of the cardiovascular system. To find these, what you'll do is just go to the end of each of your chapters, your different body systems, so kidney, endocrine. You'll see at the very end, you'll see codes for intraoperative and post-procedural complication. Now, these codes should be sequenced first, followed by a code for the specific complication if it is applicable. All right, guys, so this is the end of chapter 19. Next up, we'll have chapter 20, which is external causes of morbidity. All right, guys, thank you for listening. Happy coding.